Hi everyone, welcome back to I think this would be our 40th video, 40th Journal Club video. We have two more videos. One is this Wednesday and then we have one more next week. And then we are all finished with this endeavor that we decided to take on. I'm really excited to come to the conclusion of this project, but I'm also Dr. Attiullah, who's joining me. Sorry, let me add her really quick and then I'll finish with you guys. I just want to make sure that she can get on right away. It just says that she's adding. Hi guys, I see a few of you are watching. Nice to see you.
Hi, Christina.
Oh, hi Noreen. How are you?
Hi, good. How are you?
Good. So I was just saying that this is our 40th video. If I'm doing the math correct, because we have 42 videos, we have two left. Yeah, I know.
Wow.
And for those of you guys, I'm sure like you've heard this ad nauseum if you've been watching the videos, but if you're new, I did set up free CME for you guys. So for every video that you watch and you answer a couple of questions about it on the American Physician Institute site, the link is in every video post that you can go to. You can get 0.25 CME for each video. So that's a total of 10.5 free CME if you need any for the year. And you have 12 months to get them. So that is courtesy of API. They were very generous to do that for us. And yeah, that's what this project's been about. So that was one thing I wanted to just remind you guys of. Another one is I haven't been that active with the mailing list, but I do want to make sure that if you want to get on the mailing list, just send me an email at psychiatrynetwork@gmail.com so you can get added. Just in case, Facebook implodes or something, we still have a way to stay connected. So that's one thing. And then that way I can just let you guys know if any new events are coming up. And then thirdly, I did want to kind of look forward to like a next project for the group. So if you guys have any ideas, one thing I wanted to do was try setting up some meetup events. I'm going to start with Chicago in the next month or so. But if you're interested in helping set something up in your city, let me know and we can set up a Psychiatry Network event in a city near you. And last but not least, we do have our Women Physicians Conference. We are almost sold out of the room block and we're over halfway in our attendee goal this year. So lots of exciting stuff. We've got hiking and biking and just fun things for everyone who's interested. It's going to be in Leesburg, Virginia, September 26th through the 28th this year. And tons of great talks. Comes with CME, and you can get details on the group website, which is Psychiatry Network, etc. And that should be it. So I did want to let you guys know a little bit about Dr. Attiullah. Am I pronouncing that correctly?
That's actually excellent because everybody calls me Attiullah or Ayatollah or Attiullah.
Okay. I have a hard to pronounce last name for some people too, so I try. Not always.
I appreciate it. Thank you.
And so Dr. Attiullah went to Brown University for her psychiatry residency and graduated in the year 2000. She's been working in Rhode Island as an outpatient psychiatrist in a big hospital-based practice. She's been at her practice for almost 19 years and sees mostly people with anxiety and mood disorders, which is her area of interest. She's also been performing disability evaluations for state employees, and that's another interest of hers. She is an assistant professor at Brown University and enjoys supervising medical students and residents. She says that she loves being an outpatient psychiatrist and having a long-term relationship with her patients. And she has been a part of Psychiatry Network since 2016. So thanks for participating in this project and agreeing to do one of our last videos for us.
Well, thank you very much, and kudos to you, Christina, for organizing this. This is a big endeavor, and for you to do this practically 2 or 3 nights every week, that's really commendable. Thank you so much.
Sure.
So today I will be summarizing this review article, which is one of our required articles for the MOC called OCD Advances in Diagnosis and Treatment. And I am going to try and stick very much to the article and maybe not interject my views or commentary, but if somebody has questions, they can certainly ask me. So this article was published in JAMA in 2017. The authors are Matthew Hirschtritt from UCSF, Michael Block from Yale, and Carol Matthews from University of Florida, Gainesville. And the goal of this article, it seems to me like it's written for primary care doctors. It's written to basically identify recent advances in diagnosis and treatment in the last 5 years. Actually, that was 5 years from 2017, so between 2011 and 2016, and to present those findings. So in terms of methodology, what they did was that they did a literature search for articles involving the screening, diagnostic, and treatment approaches to OCD amongst adults, and they identified over almost 800 articles, and then they selected 27 articles, 11 of which were randomized controlled studies, 11 were systematic reviews or meta-analyses, and then 5 were review articles or guidelines. And so they go basically over, a little bit about epidemiology, about the diagnosis, differential diagnosis, and then treatment of OCD. So, for us, a lot of us may know this, but I'll just go over this again. A little bit about the epidemiology. The lifetime prevalence for OCD is about 1 to 3% in adults. The age of onset is bimodal with a peak in late childhood and then early adulthood in 20s, around ages 20 to 29. Most people, as we know, have a continuous course when they have OCD, but about 25% of people have a waxing and waning course. And it often goes under-recognized or unrecognized in primary care settings or even psychiatric settings. And I thought this was interesting. They found that the mean time from the onset of OCD symptoms to treatment has been found to be around 8 years. So that's a pretty large time to not be treated. So in terms of the diagnosis of OCD, I'm sure all of you know well, OCD is defined as the presence of obsessions or compulsions which are time consuming over an hour every day that are distressing or impairing. And then they talk about the differential diagnoses of OCD. OCD can be easily confused with other common psychiatric disorders such as generalized anxiety disorders, social phobia, eating disorders, BDD. And there's a good chart on page 1361 of this article that goes over the differential diagnoses, and I would encourage you to look at that when you have the time to go over that. So then they talk about the new advances in diagnosis of OCD, which really involves the changes that were implemented in DSM-5 in regards to OCD diagnoses. And the big change, several big changes happened, the biggest one of which was OCD was removed from the category of anxiety disorders and placed into a new category of obsessive-compulsive and related disorders with other similar diagnoses such as BDD, skin picking disorder, and hoarding. And the reasons for this was, over the years they have found from many different sources, phenotypic data, neuroimaging, and how patients respond, that patients with OCD are very different from patients with anxiety. Well, I shouldn't say very different, but different.
Yeah.
Anxiety may not be a core symptom of OCD as was thought initially. So that was one big change. The other big change was that they removed the requirement of insight. In previous versions, you either had to have good insight or poor insight. But if you had no insight, a lot of those patients would often be diagnosed with a primary psychotic disorder, and they found that they weren't getting treated adequately. So they removed that requirement, and now you can have OCD with absent or no insight. One other change was that they added a specifier of co-occurring or past tic disorder, because they found that patients with past or present tics were much more likely to respond to neuroleptic treatment. And the last change that they talk about was that hoarding was removed as a subtype of OCD and made into its own disorder under the category of obsessive-compulsive and related disorders. So in terms of how to diagnose OCD, it's still obviously clinical diagnosis. The Y box remains the gold standard, but Y box is clinician administered, so it's hard to do in primary care settings, and it's often time consuming. So they talk about two other self-report scales that I really am not aware of, but they say they have good convergence with the Y box, and that these are much more easily given to patients. And these include the Obsessive-Compulsive Inventory short version and the Florida OC inventory. So then they go on to talk about treatment. And similar to many psychiatric disorders, the data is clear that patients who get both pharmacotherapy and psychological therapy do the best. Even so, they found that 40 to 60% of patients who've had either meds or therapy endure significant residual symptoms after first treatment. So, talking about psychological treatments, cognitive behavioral therapy is widely considered the most effective treatment for OCD, and there's a lot of data to suggest it's actually even more effective than pharmacotherapy. It's effective in both individual and group settings. In terms of cognitive behavioral therapy, the behavioral part, which involves exposure and response prevention therapy, what we call ERP for short, seems to be much more effective than the cognitive part. The exposure and response prevention therapy is a type of manualized, and actually when it was developed, it was highly structured and manualized treatment that involves exposing the patients to distressing stimuli and then teaching them how to not give in to the compulsions or not to avoid. And originally the way it was developed, it was pretty intense. It involved either 5 days a week for 3 to 4 weeks or 13 to 20 weekly sessions. The cognitive part of CBT seems to be less effective and involves a cognitive reappraisal or restructuring of maladaptive cognitions. And they feel that it might be more useful for patients who cannot tolerate ERP therapy. So there is some usefulness to it or for it. Barriers to CBT, like I said, includes lack of trained therapists, the time commitment. It's pretty intense, and it also requires patient motivation, especially for patients to tolerate the distress of ERP. Sometimes that's very hard for patients. And one meta-analysis suggested that CBT delivered online was as effective as in-person CBT. And I think this is important to know because in today's day and age of telepsychiatry, I guess if the data shows that that is something that people can use more widely. So then they go on to talk about pharmacological treatments. So SSRIs are considered the first-line treatment, and meta-analyses of head-to-head trials do not show any difference in the efficacy between different SSRIs, which means that despite all the labeling differences, whether they carry the label that they treat OCD or not by the FDA, they all work pretty much just as effectively. And the recommendation is to use the maximum tolerated doses for at least 8 to 12 weeks. And there's a good chart on page 1362 that shows the starting and the target doses. High doses of SSRIs have shown to be significantly more effective than lower doses, and in clinical practice, oftentimes we use even higher than maximum FDA-approved doses, which have been shown to be effective for severe OCD. The greatest incremental benefit occurs around 6 weeks. One thing that I thought was interesting was that they said that evidence from meta-analyses suggests that as many as 25% of patients with treatment-refractory OCD benefit from SSRI monotherapy even 28 weeks after treatment is started, which I thought was surprising because who is going to wait 28 weeks with just one medication to see if it works? But, that's what the data suggests, that patients can have a significantly delayed response. So then the question always is how long to treat the patient for, and I guess there's a lot of data to suggest that the relapse rates are very high for patients who stop treatment. 50% of patients who stop medications will relapse within 6 months. So the recommendation is to continue treatment for at least 6 to 12 months after patients have shown a response. So then we talk about clomipramine. Clomipramine has been around for decades, and it was the first medication that was shown to be effective to treat OCD specifically. We know it's a serotonergic tricyclic. There is conflicting data on whether it's actually more effective. I know a lot of people say that it is, but the data is kind of, conflicting on that. Some studies show it is, some others don't. Either way, I think a lot of us think it is very effective, but has more side effects such as anticholinergic side effects, risks of seizures, arrhythmias, especially when you bump it up to higher doses. It's recommended to be used as a second-line agent. So what to do with refractory OCD? Refractory OCD can be refractory in many cases and is defined as people who don't achieve 25 to 30% improvement. And the strategies are to switch to another SSRI, try clomipramine, use CBT, or not CBD, cognitive behavioral therapy. I thought I'd clarify, and or use a combination of those. Addition of neuroleptics have also been, now it's become a routine to use neuroleptics for augmentation of OCD. The data shows no difference in efficacy between typicals and atypicals. The data does show that it is more effective in OCD with comorbid tics. Neuroleptic augmentation is effective in 30% of treatment refractory OCD patients. The recommendation is that to try it for 6 to 12 weeks, but if there's no improvement, to stop it because of the risk of adverse events, adverse effects like metabolic syndrome and EPS. You don't want that if it's not working. And once again, they make the statement that CBT augmentation is extremely effective, and for severe refractory patients, intensive residential or inpatient programs are effective at least in the short term, but the long-term data is not really, we don't have enough data if it's cost effectiveness or how long it works for. And then they talk about other new novel pharmacologic agents. There are small randomized controlled studies and open label studies that have shown effectiveness for ketamine, riluzole, N-acetylcysteine, memantine, lamotrigine, ondansetron, and several other substances, but there's not enough data for us to say that we should use these routinely. I know on Psychiatry Network, a lot of people talk about N-acetylcysteine, and a lot of people, I feel like people find that it works. So, maybe it's one of those up and coming things, but in this review article, they really don't comment on that specifically. There's just not enough data right now. As far as benzodiazepines go, there's limited efficacy, and because of the risk of dependence and really lack of efficacy in the long term, it should be used with restraint and mainly only used either in the beginning when anxiety is very high. And then finally, for severe refractory OCD, there are neuromodulation techniques, the most drastic of which is neuroablative procedures, which do have a pretty significant response rates, but of course they're extremely invasive. There is a 50 to 60% response rate after 6 to 24 months. A less invasive neuromodulation therapy is deep brain stimulation, which involves the surgical implantation of electrodes and targeted electrical stimulation of specific parts of the brain. And a meta-analysis showed a 45% decrease in post-treatment Y-box scores and a 60% response rate. And they also looked at the data for TMS or ECT to see if there's any use for that, and there is actually no good data to support the use of TMS or ECT for OCD. So then pretty much that's most of the, in terms of, pharmacologic treatments and other treatments, that's what they have to say. There is a very good algorithm on page 1364 of this article, which I suggest everyone go through because it goes in much more detail as to what to do at every step of the way, if someone improves within 12 weeks, if they improve with CBT or not, or what not to do. So definitely this is what it looks like. I wish I could go over it, but it's pretty detailed to do that right now, but definitely please look at that. And so finally in the discussion, basically what they say again is that, despite the severity and burden of OCD, it's not recognized or treated. And primary care physicians should be very vigilant in identifying, recognizing, and at least starting some, pharmacologic treatment. And if that doesn't work, to refer them on to, a therapist or psychiatrist. Cognitive behavioral therapy still has the strongest evidence for first-line treatment, with recent advances being made in telepsychiatry, and hopefully this will be something that might be available to more patients. In terms of pharmacologic treatment, SSRIs, clomipramine, neuroleptics are mainstay treatment in terms of treating OCD. And there are many new emerging pharmacologic treatments that they really, personally, I wish that I had read more about that in this article, but there wasn't that information, and they just don't have enough data on that to back routine use. And again, neurosurgery and deep brain stimulation remain options for severe refractory treatment. So, so that's about
it. That's pretty good. That was a nice summary. Thank you.
Yeah.
Do you see a lot of OCD in your practice?
I do. Yeah. I mean, it is pretty common, and I do believe it's under-recognized. I think there's a lot of shame about it. Most people, not everyone, but most people do recognize their thoughts and compulsions as bizarre, and are probably a little embarrassed or ashamed to disclose it, even to their psychiatrists at times. So, I mean, the good news
by itself, or typically comorbid with something else?
It's hard. It's rare to see OCD by itself. Oftentimes it's comorbid with other anxiety disorders, I find. Yeah. Yeah. So yeah, I think it was a good refresher article, just to go over a lot of basic stuff. Yeah, so I think it was helpful in that way.
Yeah, thanks a lot. If anyone has any questions, feel free to post them over the next 24 hours or so. It may take a day or so for this to get uploaded to the API site, but it will be there along with the other videos. And then I did forget to mention that I am a little bit behind. I know multiple people have been emailing me, and I'm a little bit behind in responses. And also, I know those anonymous posts are kind of on the rise. So I have a few I'll be posting tonight for you guys. And yeah, that's it. And you're welcome for anybody watching.
Thank you.
Yeah,
thank you for watching, and thank you for organizing.
Yeah, thanks, Noreen. All right, guys, we will see you on Wednesday. Oh, and by the way, today is actually tomorrow's the last day that we have a discount on Dr. Mago's simpleandpractical.com. He is giving Psychiatry Network an exclusive discount, $25 off his subscription with the discount code PN 2019. So if you're interested in that, it's a great resource. All right. Hi, Khadija. All right. Thank you again, Noreen. I really appreciate it.
Thank you. Thank you,
yeah, we will see you guys on Wednesday. Bye.
All right. Bye-bye.